Hello and welcome to this Davis Phinney Foundation webinar about DBS. I'm here today to talk with Dr. Sana Aslam about Parkinson's symptoms that deep brain stimulation tends to treat well and symptoms that deep brain stimulation is generally less likely to be as effective in treating for people with Parkinson's. I'm Chris Kruger, Senior Manager of Content with the Davis Phinney Foundation, and Dr. Aslam, thank you for being here with me to talk about this subject. Can you maybe start out by just giving a little bit of information about your background, how you came to be involved in treating people with Parkinson's, and what your interest is, and how you came to become interested in DBS?
Yeah, of course. Thanks for having me. So I did all of my residency, my fellowship at the Barrow Neurological Institute in Arizona, and that's where I did a DBS and movement disorder fellowship, and where I initially became interested in DBS. In terms of why it was just such an amazing piece of technology that really helped folks quite a bit, especially when we had exhausted medication options for many people. My research started in DBS at that time in terms of outcomes and exercise in DBS and things like that. And since that time's evolved into access to DBS and other advanced therapies. I'm at the University of Colorado now. I've been here almost 2 years, so a little different than the desert. But I still do primarily advanced therapies and movement disorders. So I do a lot of programming, a lot of DBS, and other advanced therapies for Parkinson's disease and other movement disorders as well.
Tell me what motor symptoms of Parkinson's we could most reliably expect to improve with deep brain stimulation.
Yeah, so tremor tends to improve quite well with DBS, even if it doesn't respond to medication, or especially if it doesn't respond to levodopa in particular. It tends to respond very nicely to DBS. And stimulation. The other symptoms of Parkinson's disease, so the bradykinesia and rigidity, also respond. Generally, we say some movement symptoms that respond to levodopa will respond to the stimulation as well. And tremor being the only exception because, as you know, sometimes it may not respond to medication, but it does still work well for or respond well to DBS.
Okay, so it sounds like any motor, I think you said any motor symptom that responds well to levodopa may respond well to DBS. Is that fair?
With some caveats.
Okay.
So, tremor, bradykinesia, rigidity tend to respond well. So, anything in our hands and feet. More what we call central symptoms. So, things that are related to posture and balance and gait, those do not respond, or speech do not respond to DBS as well and may actually worsen. Rarely, or freezing of gait in particular. Rarely, there's some nuance to this. If your freezing responds to levodopa, it may respond to DBS, but that should not be the goal. That's not the primary goal or not the main reason to get DBS in those cases. It really should be kind of that dexterity, the movements in our limbs that we're aiming to improve with with the DBS.
Okay. Thanks. So, what about non-motor symptoms? Non-motor symptom response? Yes, no, maybe? I know there's a lot of
Maybe.
non-motor symptoms too, so it's a complicated question, but can you talk a little bit
It
about this?
is. Yeah, and you're right, there are a lot of non-motor symptoms and the answer is different for different non-motor symptoms. So generally speaking, we'll say that DBS should not be a solution for non-motor symptoms or non-motor symptom burden, right? Your primary goal with DBS should be improvement of motor symptoms. That said, and depending on what target we're approaching with the DBS, certain non-motor symptoms might respond. Sleep being the main one. Sleep can improve with DBS for many people, and sleep is also a big topic. There are different aspects of sleep, but there is some data to suggest that sleep does get better with DBS. Other non-motor symptoms, however, we do not expect to improve with DBS, and some of them can actually worsen. Again, a little asterisk there is that if you have some non-motor symptoms that are worse because of medication, so for example, if you're having a lot of drops in blood pressure, so orthostatic hypotension, where you get lightheaded when you stand up, that can be worse with medication. Or if we're having, a little bit of hallucinations or things like that that are driven by medication or impulsive behavior that's driven by medication, DBS can allow us to reduce medication and indirectly help some of those non-motor symptoms. So not necessarily the stimulation directly, but more of a second order benefit in terms of allowing us to reduce some medication. and sometimes it's a little hard to say because these are also symptoms of Parkinson's disease. And so they will likely exist without the medication as well as just the degree or the severity of it. And sometimes they can be exacerbated with medication. And for many folks, they've been with their neurologist for quite some time. And so they may be able to have a good sense of how much is this medication driven and how much is the disease. Or they may not have a good idea of like, oh, it's 20% Parkinson's and 80% medication, but at least an idea of is the medication contributing? And if we're able to back up on it, will this particular symptom get better?
Great. Okay, so maybe just to sort of round out the first part of this conversation,
Yeah.
you've already alluded to and mentioned some specific symptoms that probably are less likely to improve or could even worsen. Can you just go over those again real quick, and then we can have a sort of regroup around the topic more generally? What improves motor symptoms, and maybe move on after that.
Yeah.
But what might we
And
not expect to improve?
yes. So what we don't expect to improve is cognition, mood, and a lot of the autonomic symptoms. So a lot of non-motor symptoms, generally speaking, will not improve with DBS. Imbalance, freezing of gait, postural stability will not improve. Tremor, bradykinesia, rigidity can improve. And we didn't talk about this earlier, but also motor fluctuations on, off, and dyskinesia can improve because, again, indirectly, potentially because we're reducing some of that medication, or depending on the target, that dyskinesia can directly improve with stimulation as well.
Okay, so another thing that just occurs to me that maybe is relevant here is the timeline on which we might expect. If I have DBS today,
Yes.
but my symptoms don't respond. Well, obviously, the system would have to be turned on. But if my system is activated and I have my first programming visit, but my symptoms don't improve right away, normal, not normal. What's the timeline I should be thinking about effectiveness of DBS treatment on?
Yeah, it takes a little bit of adjustment, right? So you have one, you're recovering from surgery. You've put your Parkinson's brain through surgery, and that's like a major stressor. So there is that recovery time, and that can be, it's not days, it can be weeks. And then the other part of it is the stimulation. Once we turn it on, most institutions will have multiple visits that are 1 to 2 weeks apart in kind of fine-tuning the stimulation. And while we're adjusting stimulation, we're also adjusting medication at the same time. Sometimes we're able to do them concurrently. Sometimes we'll increase stimulation first and then back up on medication. So it can take weeks up to a few months before we really kind of figure out what the new normal is. If someone has side effects from DBS as well, so speech might worsen, balance might worsen, and those could be twofold. They could either be for surgery itself or they can be related to stimulation. From surgery itself, again, allowing the brain to recover and heal and figuring out what new normal is. If you end up doing some physical therapy, the time that that takes to help re-network, reorient, so to speak, the brain. But then if it's stimulation, then that can take time and kind of fine-tuning that stimulation with your movement disorder specialist. So I usually say give it at least a couple of months, if not a tiny bit longer, before we can really say what is our new normal with our new medication regimen and stimulation. That's a lot of things that we're doing to the brain, to a Parkinson's brain in a very short period of time.
Oh yeah, it certainly sounds like the impacts can be quicker, I think. I mean, I've heard this from a lot of people with Parkinson's. Sometimes first programming, somebody has a great result and some symptoms become very well controlled for them right after that. Other
Yeah.
people I've heard even up to a year sometimes it's taken. Then after that, they have a programming visit and then it can go very well after that. So does that sound normal to you that that range
Yeah.
could exist?
And it depends, and there are a lot of factors, right? Tremor tends to respond so quickly and immediately. I mean, you'll see that in your first programming visit, that tremor improves almost instantaneously with stimulation. But then there are other aspects of the disease, and it'll depend on how long have you had Parkinson's, how much medication were you on, what are the other symptoms. We have to be mindful of mood as well, because if you are on a lot of medication and we're reducing a lot of it really quickly, we don't want to do it too quickly because losing all that dopamine can have a negative effect on mood as well. And as you well know, that can also impact how well someone feels or doesn't feel. And so it varies based on what symptom we're talking about, how long we've had the disease, how much medication we're on. So there's lots of variables to it. But being patient and just remembering that it can take time. And like you said, in the case, sometimes it can take up to a year, but then also remember it's still a progressive disease. So at the end of that year, the disease has also still evolved. And so it's a bit of a moving target sometimes.
Well, I don't think you used the word target just then, meaning a target for the DBS treatment, but I think maybe we should talk about that
Yes.
too, because
Yeah.
that's a factor as well, right? I mean, I think well, maybe you tell me, what do you think about this question? Are there any things that, maybe a person with Parkinson's should know that can impact the general effectiveness, aside from making sure that the person is a suitable candidate and
Yes.
that's reasonable, that they're a good candidate for surgery generally. Beyond
Yeah.
that, is there anything else that somebody should know about kind of what might impact the effectiveness of their DBS experience? Stimulation locations, for example, targets is why I jumped to this question.
Yeah, there are so there are two specific targets that we tend to use in Parkinson's disease: the subthalamic nucleus (STN) or the globus pallidus interna (GPI). Those are the two. STN is used a lot more than GPI. The field has swung back and forth over the years of which is better, which is worse, and I think the general I can say consensus, and this might vary depending on who you're speaking to, what institution they're at, where they trained. Um, they're somewhat equitable depending on, with the caveat of like what is the predominant symptom that we want to improve. So for example, SDN allows for a greater reduction in medication, or SDN tends to control tremor better. So if someone is on a lot of medication and we really just want to back, that's the primary goal, STN may be a better target. If they have a lot of tremor, STN might be a better target. That's not to say that you cannot reduce medication or that tremor won't respond to GPI. It will, but GPI might be a little better suited for someone who has a lot of dyskinesia on even low doses of medication. So in that case, the dyskinesia isn't driven by too much medication, it's just driven by the sensitivity of those receptors to levodopa. And so the GPI, this is a target where stimulation itself can reduce dyskinesia rather than indirectly because it's allowing us to reduce medication. And we didn't talk about this too much when we were talking about non-motor symptoms and things that don't improve or suitability of a candidate is cognition. So, in terms of the workup of DBS, a very thorough cognitive evaluation is part of it. And so if someone has significant cognitive challenges, then DBS is not a good option because it can worsen certain aspects of cognition. But if someone has some mild cognitive impairment, depending on, a little bit of nuance and like what domain specifically of processing that is affected, sometimes GPI might be a better target than STN. Or, certain things like verbal fluency can be affected a little bit more by STN than GPI. So if someone tends to speak for a living, so we've done this where, they communication, they give a lot of talks, or it might be, sort of a religious leader who gives a lot of sermons, and verbal fluency is really, really important to them, then we may say, well, let's pick a different target because, that is a big quality of life factor for them.
Okay, so is there any, maybe I'll jump and ask you another question related to this. Is there any other
Yeah.
sort of, um, I don't know, like a variable, I guess, that might
Yeah.
relate to how effective a person's DBS treatment will be?
Yeah. I mean, I think so there are different devices. And each of the devices, there are different companies that make these devices, and each of them have some, different features that are unique to them. One particular company allows you to have your images on there and sort of model the stimulation specifically to your brain anatomy, which is really cool. They can now use AI to kind of generate the programming parameters because as these devices get more and more complicated, that means more and more options for programming. And so it can almost be endless options. And so incorporating your technology into figuring that out. So one of the companies allows for that. One of the companies allows for the lead to actually listen to the brain, so to speak, and listen to the activity in the brain, and then also respond to it. And so it's adaptive, in that it adjusts the stimulation based on the firing pattern in the brain. And so if that firing pattern is stronger, for example, because meds are low, then it may increase stimulation, so adjusts it accordingly over time. And so that's a really cool feature that's newer. And then the third company allows for their unique aspect is that it allows for remote programming. And so if if you live in a more rural area or the nearest center where you got your DBS is quite far and it's really hard to keep up with those appointments or drive hundreds of miles for those appointments, they do allow for remote programming where you can just have a virtual visit and they can connect to your programmer virtually. Um, There is still some difference in kind of how the stimulation is delivered between those, but those are kind of the major differences between the companies.
And I think, tell me if I'm right or wrong here, but there are
Yeah,
different types of leads too. Is that right? That I mean, there's directional and non-directional. Does anybody use non-directional leads now, or is that?
not really anymore because like all of them have a directional lead now.
Can you just
So
describe what that means and why that's relevant?
yes, yeah. So let's back up a tiny bit. I'm gonna give you my little spiel about how DBS works.
Yeah,
So,
great. Thanks.
excellent. So, here we go. So this is obviously much bigger, but a DBS lead is tiny, tiny lead that goes into the brain. So the brain is all about networks, and the STN and GPI are big hubs in the movement network. And so we know that if we can kind of jam that network a little bit, so to speak, that we can control some of the movement symptoms that people have: tremor, bradykinesia, rigidity, dyskinesia, depending on what target we're using. Um, and a way to jam that network is to do little pulses of electricity, which is what DBS does. And so we put these little leads in the brain, in those parts of the brain. Each lead at the bottom has little rings around them, usually four, or there's actually more even now, that allows us to generate little electricity, little pulses of electricity. We can change how fast it's firing, how strongly it's firing, how quickly it's firing, the interval between firing patterns. And so historically, these were just completely circular leads. And so you would generate this sphere of electricity, so to speak, or stimulation around those. Over the years, we figured out because, anatomy can vary, surgical placement can vary, leads can turn, leads can move. Then there's and these are tiny, tiny structures. So just a few millimeters of a difference, of a change can make a lot of difference. We also learned that when we talk about STN and GPI, each little area of these structures also has different aspects and different networks that it's controlled. So it's not just like this homogeneous network. There's a little, variability to whether you're stimulating laterally or medially or more above or more below. And so we decided to kind of section off these leads a little bit. And so they have segments. And that allows us to kind of move that stimulation a little bit around and allows us to kind of shape that field a little bit better. So if I'm getting side effect because the stimulation's spreading too much into a structure nearby that I don't want to, then these segmented leads allow me to kind of shape it and redirect that field in a different direction that's going to help symptoms but not cause side effects. So that's a really long answer to describe what segmented is. But all three companies allow for segmented now. There's really no reason that I know of for at least Parkinson's to not use that.
Okay, so it sounds like that it's not so much that that might well, it could affect maybe the programming process. I guess that relates back to that point, right? That it may take
Yeah.
a little while because there's so much sort of not control exactly, but so many types of changes one can make to the programming that could really make a big difference in the efficacy. So it's part of am I right? That's part of the equation there in terms
Yeah,
of the
very much
scientific.
so. It allows more variability with programming and a lot more options with programming and kind of the nuance of programming and stimulation itself. I mean, over the years, and this is another slight variable between the companies, is, how that current is delivered to each of these contacts as well. And so it really, yes, you're right. A lot of it comes down to programming and the options available there.
Great. So I think I'd like to see if we can't just, as we start to round out this conversation, can we get kind of restate the core points for the audience
Yeah.
and just say what things are most likely to respond well, what things are less likely to respond well, and,
Mhm.
what are the core questions you would recommend somebody ask about symptom control if they were going to be considering DBS? So symptoms that respond well, symptoms that respond maybe less well, and what would you recommend people ask their providers if they're talking about DBS surgery in the early stages or in the early part of having that discussion?
Yeah. So tremor, rigidity, bradykinesia. So respond very well to DBS. Central symptoms like balance, postural stability, and central non-motor symptoms, so like cognition, speech, mood, those do not respond well to DBS and sometimes can worsen potentially. DBS does allow for medication reduction, and so thinking about that is important. And that is a discussion about which target that someone might pick. And then questions to ask your provider or your physician are, what target are we picking? Why? That's a reasonable question and discussion to be a part of. What can I expect to improve? What will worsen? How long is programming? What is sort of the protocol here? And that can vary, and it can vary from person to person. Um, And then also having, longer conversation about the devices and kind of what works for your lifestyle, what doesn't. There are even things to think about in terms of where you live. If you spend part of your year in one area and there are programmers there that are familiar with one company but not the other, and or if you have physicians that, in one part of the country and a different part and they don't both, are comfortable with all of the devices or the device that you get, or you're planning to move in the near future to an area that may not have as many specialists, these are things to kind of think of. They're not the biggest factors, right? But they are little things that affect quality of life that might be worth thinking about.
Well, thanks for that. I want to jump to quality of life if we in a second, and maybe that can be
Yeah,
maybe the round out the conversation there, asking you about your general sort of what the research says generally about
yeah,
quality of life. Before we do that, I want to ask you about the one last question, if I can, about central symptoms and specifically gait, because we get a lot of questions about this.
yeah,
Um, I know people say, they're freezing of gait, for example. Many people, medication doesn't really help with that for a lot of people that I've talked with. But
yeah,
there are people who have gait disruptions that do seem to respond well to levodopa. For example, if the footfall can't be controlled or something like that because of bradykinesia or something to that effect, is that
yeah,
it would could that be responsive or is that not? Do we not see that? What do we see?
yeah. And that is also like that's a good question to kind of ask the movements when as you're going through the DBS process. It's like, hey, my gait is affected because gait is, it's a very general term, and it can be like you said, pointed out from different reasons. It could be gait could be affected because you have dystonia in your foot. Gait can be affected because we have a lot of freezing, or gait could be affected because we have other, also have peripheral neuropathy, and that's affecting gait. So if gait is not great because, that rigidity and bradykinesia is worst on one leg and, we're dragging that leg, then DBS may be helpful because it may improve those symptoms, or the dystonia might get better. But, or like I said, if the freezing of gait responds to levodopa, sometimes that will also improve with DBS. So you're right, that's not, often the case necessarily. I think more consistently, it's that postural stability. So that imbalance that is related to, kind of losing your balance when falling backwards, that it is very difficult to improve and may actually worsen sometimes with DBS. So you're right, gait is a little bit more nuanced than just kind of generally speaking, but usually we'll say if balance is probably the bigger term that we'll use, is that if that's the primary goal with DBS, then we need to have a longer discussion about expectations.
Great. Okay, well, thanks for that clarification and a little
Yeah.
more detail there. So maybe to close up, what does the research say about reasonable expectations for overall impact on quality of life? Is there research that is citable about that you'd recommend we think about? And do you have any answers to that question?
Yeah. So, I mean, a lot of our studies, quality of life metrics are a big part of those outcomes, right? So we talk about these UPDRS scores, which is a way of grading things, and like, what does a 3 point or 5 point difference really mean, if it doesn't improve quality of life? And so there are a lot of these scales, most of these studies have quality of life metrics, and DBS does improve those in terms of improving motor symptoms for folks. And then in longer term studies at 5 years and 15 years, we've found that DBS continues to help those motor symptoms over the long run. It's just that there are different challenges because DBS is not slowing down disease, it's not disease modifying. So there are different challenges with the disease as we progress, but it continues to help with those movement symptoms over the years and long term.
So I just want to wrap this up, I think, by saying that each person's experience is going to vary overall, right? But
Yeah,
also from over time, as you just noted, that Parkinson's will continue to progress once one has DBS. At this point, nothing we have changes the sort of we don't know anything that changes the progression of
yes.
Parkinson's. But that doesn't mean that the effectiveness and the quality of life improvements might not also change and could potentially improve over time depending on how your symptoms evolve. Is that fair to say that that's one
Yeah.
advantage of DBS?
Yeah, for sure. I mean, like it still work. We have found, and just when we actually, not just anecdotally, but like when we have tracked people over 15 years, that it continues to help those motor symptoms over the years. And so, that quality of life may be worse. It's likely worse without if we hadn't gotten DBS for those individuals. That said, DBS isn't for everyone, and so there is this, we haven't talked a lot about the screening process, but it varies from center to center a little bit. But there is a screening process, and to be patient with that as well, because the screening process can take time. But the reason it takes time is to make sure that DBS it's brain surgery. It's a big deal to make sure that it is the most appropriate option and that the risks and benefits are equally balanced in those cases.
Yeah, thanks for reminding us that the whole process, the whole life cycle, so to
Yes.
speak, of considering DBS does take some time. So,
Yeah.
it's important to start thinking about this maybe a little bit before you think you might be getting to the point where you would need the DBS relative to how much your medication is helping you. Need obviously is
Yeah.
a variable for people, but the
Yeah.
fact that it takes time is an important thing to know as far as the effectiveness of managing symptoms because, you know, well, you tell me, is that
Yes.
right? That
Yes.
the timing is important for
It
relative
does,
to this?
yes, very much so. And I mean, there's different literature. Like the original studies that looked at DBS were, 11 and a half years into the disease. And, over the years we did, studies earlier and we found that when we do it earlier, and that's like 7.5 years into the disease, that it had a significant impact on quality of life. And then there's some other studies that are investigating whether there's value in doing it even earlier. So it's not it used to be thought as a very last resort, and it really shouldn't be anymore because there is a window of DBS. You can get enough of these non-motor symptoms or progression of the disease where DBS is no longer an option, and that it w would significantly negatively impact quality of life if you got it at that stage. So it is a big window, but it is a window. And so kind of starting to think about it earlier with a lot of my patients, I'll start kind of, mentioning it when I think we're heading to that direction in the next year or two. And it's like, you know what, I think we're going to have to talk about this a little bit more seriously in the next year or so. Just to kind of think about it and do your research and ease into the idea, so to speak.
Great. Well, thank you very much, Dr. Aslam, for your time and sharing your expertise with us. Is there anything I didn't ask you that you think I should have?
No, I was gonna say another sort of with the long term and like looking at the future with DBS is, we talked about how non-motor symptoms are not really helped with DBS, but I should say there's a lot of research going on into how can we manipulate DBS to help some of those symptoms. Who knows whether that will pan out, but there is some interesting work being done into specific stimulation and specific parameters. So there's a lot more yet to be done with this, I think.
Great. Well, thanks for sharing that nuance too. I know a lot of people are interested in developing technologies and developing treatments, so it's important to know that there is research going on in that way. Thanks for sharing that.
Yeah, of course. Thanks for having me.